Good evening, everybody. Thank you all so much for coming. I know it's probably been a long day for many of you, but welcome to the session on criminalizing people and practices, HIV and the law. We're very excited to have been able to put this session together, and would really like to thank all the conference organizers and everyone who made this possible. So we've just got an hour, so we're going to keep all questions for the panelists till the end. And if we don't have enough time, I'm going to ask all the panelists to stay, and you can chat and ask them any questions you might have after. So without further ado, I'm going to introduce all the panelists very quickly and then get them going on their presentations. So first of all, we have Dr. Kate Shannon, who is the Director of Gender and Sexual Health Initiative at the BC Centre for Excellence in HIV and AIDS. She is an assistant professor at the University of British Columbia. The next presenter we'll have is Dr. Carmen Logie, who is an assistant professor in the University of Calgary. Next will be Dr. Stefan Baral, who is a physician epidemiologist and a member of the faculty of the Department of Epidemiology at Johns Hopkins School of Public Health. Next, we'll hear from Richard Elliott, who is the Executive Director of the Canadian HIV/AIDS Legal Network. Next, we'll have a short presentation, a video from Michael Vaughan, who is from the BC Civil Liberties Association. And then last, we'll hear from Michael Fetter, who is a partner at the McCarthy Tetro, and it was represented the British Columbia Civil Liberties Association at the Maboire and DC case concerning the criminalization of HIV non-disclosure. So I'm going to ask Dr. Kate Shannon to give our first talk.
Great. Thank you very much, Cora, and thank you everyone for the organizers, and particularly for Cora and Stefan Baral for organizing. So today I'm just going to be talking briefly, or as briefly as possible, about criminalization of sex work and some of the ongoing policy as well as legal and court challenges in Canada. So really briefly, as I'm sure everyone knows, sex workers continue to face substantial health inequities globally. And in a recent review last year by Stefan Baral and colleagues, sex workers were found to be 13.5 times more likely to experience HIV than women of the general population of reproductive age. We also know that within North America and many settings globally, sex workers continue to experience significantly higher rates of violence as well as mortality. However, we also know that poor health, HIV risk, and violence vary substantially both across and within regions, and vary significantly by social, legal, political, and cultural contexts. Unfortunately, within the Vancouver context, and certainly in many West Coast cities, over the last 2 decades, we've continued to hear of many women who've gone missing, and of course, many are familiar with the Missing Women's Inquiry, and unfortunately, the Missing Women's case within the BC context. This is a poster from the Wish Drop-In Centre in Vancouver, which is the main drop-in centre that services sex workers on evening hours, and has just recently opened overnight, as well as a quote in reference to the missing women in Vancouver. In the Canadian context, there continues to be a substantial gap between political and moral ideology and science. And while I won't go into substantial detail, I do want to point that there have been 3 separate parliamentary subcommittees since the 80s that have been pulled together that have traveled across the country, heard from experts, including sex workers, academics, legal experts, and have consecutively concluded that the status quo with respect to sex work is not working, and have gone on to say that the laws are actually contradictory and failing to protect sex workers. While these consecutive parliamentary subcommittees have concluded that the status quo is ineffective, consecutive governments have really failed to do anything or listen to the evidence. As a result, what's really where we're really at right now is that sex workers have been forced to push these cases through the courts. So in 2007, there were two separate sex work challenges launched, one in BC and one in Ontario, to challenge the constitutional laws related to Canada's prostitution laws. In particular, while sex work, for those that don't know, the buying and selling of sex in Canada has always been legal. It's illegal to communicate in public spaces for the purposes of sex work. It's illegal to live off the avails of prostitution, so that extends to family, friends, partners. And it's also legal to operate a common body house, or work in a common body house. So some of the data I want to present to you very briefly is drawn from an ongoing community-based research study that was initiated in 2005, and it was extended in 2009 to street and off-street sex workers across Vancouver. It includes both quantitative as well as qualitative work, and we continue to work with a range of community partners and advisory board members. So some of the qualitative work that really speaks to how there continues to be substantial gaps between policy support for sex workers, and in particular how criminalization and enforcement of current sex work laws really put sex workers at vulnerability for violence, poor sexual health, and HIV risk. So this is work by Lisa Lazarus, who's a student working with me, who did some qualitative work that looked at experiences of the most marginalized sex workers, so street-based sex workers or street-involved sex workers who are living in low-income housing. And this qualitative work really spoke to how sex workers were constantly evicted, had little protections by living, not being able to bring clients indoors to their workspaces. So they were either evicted or told and forced to work in really isolated spaces as a result. Another work was also looked at the role of occupational stigma and the role of stigma and fear of disclosing sex work status, and how this really continues to be a major barrier to health access. In terms of criminalization, we've also published a number of studies that have really highlighted the major gaps, and I'm not going to be able to go through all of them today, but I wanted to draw your attention to one that I really think speaks most closely to some of these gaps. And in particular, this was an analysis just looking at some of the structural and social factors, as well as individual and interpersonal factors associated with reduced ability to negotiate condom use or client condom refusal. In this case, when we did an initial analysis just looking at factors associated with inability of sex workers to negotiate condom use, servicing clients in cars and public spaces compared to indoor settings, violence, enforced zoning restrictions on working in main streets, and enforced displacement away from main streets and commercial areas were the key factors that remained associated with reduced ability to negotiate condom use with clients. And this was depicted as well in the mapping that we subsequently did, where you'll see the larger sort of purple or pink circles on the outside represent more isolated industrial areas in Vancouver, where sex workers reporting increased hotspots or clustering of being pressured into unprotected sex by clients. So really we see how criminalization and enforcement displaces sex workers away from main streets and into isolated spaces, and really reduces their ability to negotiate condom use, having to rush transactions and not having the protections afforded to them to be able to assist on condom use. So much of this work by ourselves and many others across Canada has continued to feed into many of the policy discussions, particularly in the Canadian context. And what I think is important to note as well, there's been continued work done over the last 2 decades, and the last decade in particular. There continues to be a significant shift, particularly in the last few years with the Ontario case, in terms of Canadians' perspective and the general population on Canada's prostitution laws. And this was the most recent poll that had 80% in favor of policy reform. So really showing substantial good dialogue and information out there in terms of public understanding of the issues and the needs to really reform prostitution laws in Canada. There's also a critical need, and we've tried to demonstrate this as well as many others within the Canadian context, in terms of accountability to the public health community, in terms of how this impacts HIV as well as public health policies more broadly. And in particular, many others, and there's about 10 groups that are currently intervening in the case in Ontario that's now going forward to the Supreme Court of Canada. And this was actually a media release when we co-intervened with the Canadian HIV/AIDS Legal Network in the Ontario Court of Appeal in respect to the Ontario case going forward. And certainly I think there's a continuing need to feed into discussions, but hopefully this case that we'll be hearing will uphold the original decision. And so in Ontario, the first case at the Ontario Superior Court struck down the prostitution laws in Canada. So all of the living off the avails, communicating, as well as keeping a body house. Unfortunately, we didn't see the same decision at the Ontario Court of Appeal, but 2 of those laws were still upheld. What's really important about this Ontario decision, and why many of us have been intervening in the case, it's been very clear, hearing from many sex work experts, legal experts, as well as researchers, the critical negative impacts of criminalization enforcement. And the decision was really landmark in really recognizing the strong body of evidence and really making a decision based on that. And as I mentioned, unfortunately, within the Ontario case, at the Ontario Superior Court of Appeal, at least, while two of the laws were upheld, the communicating code was not upheld at the Ontario Court of Appeal, which means that should the Supreme Court decision or Supreme Court that's hearing the case this spring side with the Ontario Court of Appeal, it would continue to remain illegal to communicate in public spaces. And certainly, given that marginalized sex workers within the street-based context continue to be the most impacted by the current sex work laws, it's certainly concerning and continues to see substantial health inequities, particularly in that population. One last piece I wanted to mention, and I think is important because of many perception in terms of what a bawdy house is or brothel is this is work where we had the opportunity, it was led by a PhD student, Andrea Cruzy. We had the opportunity to evaluate two housing programs that are operating in Vancouver by Atira and Rain City that were supportive housing, women-only housing programs, but had developed supportive policies for sex workers and have really allowed sex workers to work within the confines of their own rooms. And a really important example of how safer indoor sex work spaces can promote health and safety for sex workers. And ultimately, should the decision at the Supreme Court of Canada strike down Canada's prostitution laws, these are the sort of supportive environments that can afford health and safety for sex workers. And I just briefly want to mention that certainly there was substantial support, including by, these are quotes from both Perry Kendall, the BC Provincial Health Officer, as well as Patricia Daly, the Chief Medical Health Officer of Vancouver Coastal Health, in support of the safer indoor workspaces and the critical role they play in terms of health and safety. And for the most part, that was well played out in terms of the media discussions that the community was able to put forward based on this report. We also had the opportunity to feed the specific paper into the Supreme Court of Canada this January to help shed light on other examples of bawdy houses that may not be the context of a specific brothel, and to also highlight that there are a range of options that should these laws fall, would allow for most marginalized sex workers to have access to health, safety, and really ability to negotiate sexual transactions, including HIV prevention. So in conclusion, I really just want to highlight that there really is strong evidence both across Canada as well as internationally that the status quo of criminalization of sex work and punitive sanctions targeting sex workers really continue to fail sex workers and increase harms, including HIV and violence. In addition, the fact that criminalization as it currently stands in Canada really hampers our ability to roll out evidence-based public health and violence prevention initiatives, including examples such as formal safer indoor workspaces, access to occupational health and safety standards. And there certainly are examples internationally, including New Zealand and parts of Australia, that we can look to that have decriminalized sex work and have adopted some of these policies, including occupational health and safety standards, to ensure increased access for sex workers. So there's really a need to look at evidence elsewhere and hope feed into improved supportive policies for sex workers. So I just want to conclude with some acknowledgements. Thank you.
Hello, everybody. Thank you so much for coming here today. I'm sure you've had a long day. I'm going to be speaking about legal challenges experienced by diverse women living with HIV in Ontario. And I want to acknowledge my co-authors, which include Lena James and the principal investigators of the study, Wingari Throw and Mona Lutfi. And so basically, just to give context, we know that HIV infection rates are increasing among women in Canada, and marginalized women are disproportionately impacted due to social and structural factors. And this was part of a large 5-year study that I've been involved with Women's Health, Women's Hands, and Women's College Research Institute. We engaged peer research assistants in 5 different cities, Thunder Bay, Sudbury, Toronto, Ottawa, and Hamilton, and we used a community-based approach. We did 15 focus groups with very diverse women, including Aboriginal, African, Caribbean, South Asian, Latina, and obviously a lot of these groups are intersecting sex worker, people who inject drugs, people who are formerly incarcerated, lesbian, bisexual, queer, and transgender women. So there was a lot of diverse voices heard here. We also had 4 focus groups with service providers in Toronto, Ottawa, and Hamilton. And so this is really guided by an intersectional theoretical approach, which I'm going to be describing in a moment. And so the objective of this particular presentation today is to look at structural barriers and social barriers experienced by women and how those are shaped by their experiences with the law. And so if you want to learn more about our intersectional stigma approach, this is a paper we published in PLOS Medicine that looks at the intersection of HIV, gender, race, sexual orientation, and sex work, and how they operate across micro, meso, and macro levels. And we also looked at specific challenges faced by HIV-positive lesbian, bisexual, queer, and trans women in Toronto. And that's in the Journal of the International AIDS Society. And so when I was rereading the data, just to really understand how law shaped the experiences of these very diverse women, there was 2 major themes that I found. One was how criminalization of HIV and transmission is experienced, and there's voices against and voices for, and also how a precarious immigration status impacts everything from violence against women, healthcare access, and education access, and family reunification. So a lot of voices against transmission were basically around how one woman described that she was deported because she was involved in sex work and HIV positive, and another woman, and this is echoed across many, many focus groups, was that women who are living with HIV were afraid to get involved in relationships because they didn't want to have to disclose their status and experience stigma and discrimination. And so they were concerned that the criminalization of HIV transmission would exacerbate that. And most of the voices that supported HIV transmission, and I wanted to include both perspectives because this is what the data showed, were from people involved in sex work. So a lot of people said that possibly Johns would target them because they were sex workers, and somebody said, it's murder. This is from a sex worker. If you don't want to press charges, you can't get compensation. So there was definitely voices for and against. And so what else that really emerged was this precarious immigration status and how it impacted people's lives. And so with violence against women, we saw that violence against women was really shaped by the precarious immigration status as well as inequity when there were serodiscordant relationships. And this was really manifested within acceptance of self and the partner's acceptance of oneself. So one woman described that a lot of this is accepting yourself. A lot of people have been, a lot of my boyfriends have been HIV positive, and it's really hard to have a normal life. Then another woman was talking about, well, why are you with someone like that if I had HIV and my partner didn't have HIV? And I'll just skip ahead here, but this is really intersects with precarious immigration status. A lot of people were talking about, so I'll give you one example from an African Caribbean woman. I want to talk about women in violence. Sometimes a woman has a partner, they cannot get out of the relationship if the person has no papers. The person has papers. When it comes to violence, you cannot leave him because no one wants to sponsor you. And so you have nothing. You have to stay home, and every day is hell with your partner. And this was echoed again and again with service providers. So when women who are HIV positive were sponsored to come to Canada by their partners and they were experiencing domestic violence, they really felt like they didn't have any place to go. A service provider said, many people come, they have no financial security and are dependent on the one who sponsored them. Sponsorship laws are different. And another service provider was saying, as newcomers, not everyone knows about their position or their rights. So we've seen women who've been abused and told they had to give their passport to their husband, or their whole immigration position is abused as well. And so this also shapes context of internalized stigma. So when people have HIV, they might not want to leave their partner because they said, you might not find another person to love you, to treat you the way he was treating you before. And so there's also this, and this is what I found particularly interesting, is a lot of women that I did these 15 focus groups, as well as the 4 other focus groups, a lot of women said they would rather sleep on the street than go to a violence against women shelter because of this stigma discrimination they faced within the shelter system, because a lot of times shelters take their HIV medication and then they take medication from people, and so they're discriminated against. So here's an example. It's immigration, domestic violence, refugee status. The legal system here, it doesn't take these women, and it's all connected. When the question of health issues come, some are not eligible if they're refugees or if it's women on sponsorship, so they're financially dependent on the other person. And I'll just give you a couple last examples. So one young woman living with HIV said, "I'm not a citizen, I haven't got my papers, so for me it's kind of hard because you don't have your papers and medication." And a service provider said it's a big battle to get access and services. Maybe people applied for refugee status, they were denied, they went underground, and they've never gone to see a doctor. And another woman explained how this impacted her access to education. So I'm facing immigration. When people don't have immigration papers, it's hell to get education. If you don't have education, you can't get access to a good job, and everything is horrible. If you can make it easier, policies for immigration for people living with HIV. And then I just also wanted to highlight this is about family reunification. If you're positive and you want to sponsor somebody from your country, it is not possible with immigration. Can we do something about it? We can't all remain single for life. And another woman described, when I was sick in 2005, I was very ill. My doctor helped write a letter to immigration to help bring my brother because I wasn't working, and he went to be interviewed, and they asked him, "Is your sister working, babysitting? How are you going to live?" She's getting ODSP. And so she said she couldn't even walk, and she had problems eating. And so a queer woman living with HIV said, for newcomers, public health should, when the public health comes to tell you about your status, maybe you need to go one-on-one, fill out the form, they'll give you the organizations you can go to. And so she's recommending that the Public Health Agency of Canada better link up services and all the supports for when people are testing positive. So to sum up, legal issues impact women living with HIV in multiple complex ways. There's different discourses on criminalization among women. In this data, it was particularly among women involved in sex work, and how precarious immigration status impacts the agency, the personal agency people have to leave situations for interpersonal violence, access to healthcare and education, and family reunifications. So this really does have implications for tailoring services for women living with HIV with different immigration statuses, women living with HIV experiencing interpersonal violence, and really us to think about policy and access to healthcare and education for people who are undocumented, and flexible sponsorship agreements for family members who are on ODSP, particularly, so that's, I should say that for people not from Ontario, so it's disability plans, particularly for sponsoring family to provide health care. And I just want to acknowledge CAHR for funding, the community-based collaborators in all of the different cities we worked in, and in particular, Women's Health and Women's Hands Community Health Center in Toronto. Of course, all the participants and the peer research assistants. And feel free to contact me for further information.
Right. So I'm going to be switching gears a little bit, and I'm going to be talking about the needs of gay men and other men who have sex with men, and then the other shift is that I'm going to be talking about settings outside of Canada. So I thought I needed to do a disclosure, but mainly this funding comes from USAID and the National Institutes of Health in the States. So as an outline, again, I'm going to talk first about the burden of HIV among men who have sex with men in low and middle-income countries. And the reason I'm doing that is because traditionally, I think we've always associated the needs of gay men as being a high-income issue. Many of us recognize that there's great needs among gay men and other MSM in low and middle-income countries as well. I'll talk about how we've conceptualized the prerequisites between prevention science research as well as programming, and then talk about some case studies from the Gambia as well as Malawi. Talk a little bit about the relationship between stigma and prevention expenditures and some thoughts on moving forward. So when we did a systematic review looking at rates or prevalence of HIV among MSM, what we found was actually there's a remarkable consistency of the burden of HIV across the world. And so whether you're looking at North America or Central and South America, Sub-Saharan Africa or South and Southeast Asia, you see between 14 to 18% of MSM living with HIV. You see the highest rates in the Caribbean, and you really see some of the lower rates in Western Central Europe. And where you don't see any data in terms of some parts of Central Africa, Northern Africa, some parts of South America is really where stigma has just been too aggressive so as to be able to do this research, and in terms of guaranteeing the safety of your participants as well as your staff. I'll just briefly look at this slide, which compares the HIV prevalence among men with sex with men as compared to that in the general population, and point out Sub-Saharan Africa and Caribbean. In Sub-Saharan Africa, it's because we associate these with generalized epidemics, and the Caribbean in terms of the most generalized epidemics in the Western Hemisphere. And in each of these settings, when you look at the burden of HIV among MSM, you see that it's far higher than that of the general population. So again, even in the context of more generalized epidemics, you still see a disproportionate burden among these men. And whereas a few years ago, we really didn't have much data from across Africa, now you can see a significant amount of data from Southern Africa, Eastern, Western, Northern Africa. And in each of these settings, the burden of HIV is greater than that in the general population. And especially in Southern and Eastern Africa, which are female-predominant epidemics, when you compare them to other men, you see significantly higher rates. And again, you really just see large amounts of missing data from countries where it's just too difficult at this point to do this work, but that's potentially changing. So then in terms of moving forward, so we've established that there's a high burden of disease among MSM in all settings, and so we need to think about what we're going to do about it. So, now I think it's well accepted that prevention packages are going to come in terms of the three main components, in terms of behavioral, biomedical, structural interventions, and there's a clear growth especially among biomedical interventions in terms of oral or topical antiviral chemoprophylaxis, so the IPREX study for MSM. Rectal microbicides are all coming through the pipeline as we speak, and there's a series of phase 1, phase 2, and 2B trials. And then treatment is prevention. So 052 included some sites that were focused on MSM. So thinking how you would operationalize these studies among MSM and how you would test them, and then also how you would translate them to programming, is that you have to be able to identify gay men, right? So people have to be willing to self-disclose in these settings. You have to be able to appropriately risk stratify these men, so that, especially in the context of PrEP, and potentially so in terms of couples-based approaches. And then also you have to be able to do meaningful follow-up, right? So you have to be able to see the same people at least a couple times in terms of knowing whether there was any efficacy or effectiveness associated with your intervention. So people have to have trust in the healthcare facility that they're going to be safe coming back to that facility. So I'll just look at the Gambia and Malawi to sort of see how some of this plays out in some of the places where we've worked. So the Gambia is a little country sort of totally encapsulated, it's a little English-speaking country totally encapsulated within Senegal in West Africa. And the epidemics in West Africa look very different than Southern and Eastern Africa. They look more like Asia or Latin America in terms of them being far more concentrated among key populations, including MSM. So in our study, the prevalence of HIV among MSM was about 11% compared to about 1% in the background, and probably about 0.5% among in the general population. In our study, one of about 40 men were aware of their status as living with HIV. So about a year ago to the day, there was 20 men, I don't know if it made news in Canada, but there was about 20 men arrested, accused and ultimately arrested. And when I say men, I say it lightly. I use that term loosely because they were teenagers. Most of them were under 19. I think there was one 20-year-old. But the statement, the charges read as follows. You jointly attempted to commit an unnatural act. So an unnatural act is sex between men. By conducting yourselves in an unindecent manner, this is their writing, not mine, in a public place, thereby you committed an offense. He says, you jointly conspired yourselves to commit a felony therein with financing an occasion in which an indecent act was about to be committed. So talking to these guys, and I should say, fortunately, after 4 months in prison, they were released through a lot of advocacy by local organizations. But when you talk to them, it was a party, and police just raided this party. They had inside word. They were there. They were taking pictures, but nobody was having sex. People were just having fun and dancing. But the outcomes, while it seems a little ridiculous, the outcomes were very serious. So this was just taken in the first month after this. Gambia is over 95% Muslim, and so imams are very powerful. The top left is saying death and hellfire for homos from one of the main imams in the country. And there's ironically, I think there's 3 human rights commissions, all based in Banjul, the capital of the Gambia. And the Europeans were giving President Jammeh another prestigious human rights-related award on the same day that Operation Bulldozer was launched, which was to bulldoze out any homosexuality in the country. And even as of a few days ago, President Jammeh continues warning all of us, any foreign-born or domestic homosexuals from ever visiting the country, or they shall regret being born. So in terms of how that plays out then, in terms of associations with disclosure, right? So that is to say that 4% of the MSM that we had studied had ever disclosed the fact that they were MSM to any family member, and about 15% had ever disclosed to a healthcare worker. And when you look at the associations, you find that those who had ever disclosed to a healthcare worker were far more likely to be afraid to seek healthcare services, and were 10 times more likely to be denied healthcare services. So again, when you're thinking about doing prevention sciences research or programming, you're imagining that when these people leave these services and have been denied and kicked out of the clinic, it's unlikely that they would tell their peers that they should go in there and tell them exactly what their risk factor was for either the acquisition or transmission of HIV. In Malawi, the prevalence, again, of HIV is far higher among MSM than it is in general population, although in this southern, eastern African country, it has a more generalized epidemic than in the Gambia. And in 2010, there was a traditional wedding between a man and a transgender woman, Stephen and Tawange, which set off sort of a firestorm and witch hunt. Police were hunting for prominent gays and were closing in on gays and tracking down gays. And so you can imagine yourself living as a gay man in these settings, how you would feel about disclosing your sexual orientation or your practices to healthcare workers or to anybody for that matter. This was from a workshop where we were just training media about these issues, and people stormed in and gave us a petition to sort of get out of town, which we did. And also the president at that time, noting again gays being worse than dogs, and this thing about, have you ever seen a he-goat attracted to another he-goat or a male dog to another male dog? So it's interesting because the answer is, as all of us know, is yes. And what's interesting is that this has sort of become a rallying cry of Mugabe and Mutharika and Jammeh and others, and I find that quite ironic. But nonetheless, Bingu died of supposedly natural causes, and so we don't miss him. So nonetheless, from a study in terms of how this played out, in looking at a study of MSM in Malawi, Namibia, and Botswana, what we found was that with any interaction with the healthcare system, people were far more likely to be afraid to seek healthcare services. People were far more likely to be denied healthcare services, and also they were more likely to be blackmailed as a result. And this was especially true among those people living with HIV, right? So these people were almost exclusively denied healthcare services and far more likely to be blackmailed, again, either because they were living with HIV or because they're MSM. And so again, you can imagine people's willingness after they've been blackmailed and they've been denied healthcare services to again disclose that to anybody, right? To tell their peers to disclose these practices. I want to sort of finish on a little bit positive. It was just to say that in Malawi, again, Mutharika died. The new female president of Malawi has promised to overturn the ban. And this is a picture of a poster, a billboard taken just last month in Blantyre saying sexual minorities have rights too, uphold, protect, and respect their rights. And so really showing that there seems to be a sense of change there. But the messages are clear, right? That we can't do prevention science research, and it's going to be even more difficult to do meaningful programming if people are living afraid, are hidden, and have limited access to safe and effective clinical care. I just want to briefly say that stigma doesn't just live in Africa or South and Southeast Asia. It lives in Washington, D.C. It's alive and well in Geneva, and I'm sure it's alive and well in Ottawa in terms of how things are funded, right? So in concentrated epidemics, which really makes up the majority of the world, where MSM are basically the predominant risk group, with some settings where injecting drug use and sex workers are also important, about $3 out of every 100 non-treatment dollars support their needs. And in generalized epidemics, where we're showing this emerging evidence, there's basically been almost exclusively outside of South Africa, very little money, $0 really being spent on their needs. And we have a couple reports that you can look at that we've done with AMFAR that have explored this issue in more detail. But there's a few clear themes from this, which is to say that 3 decades into the pandemic, we really know very little about the needs of gay men and the burden of disease and the associated factors with MSM in much of the world. I would venture to say most of the world. And stigma and rights violations and HIV are intricately linked, right? So stigma limits our ability to do this research. It makes it unsafe. Stigma limits our ability to fund this research. And also, ultimately, it limits your ability to provide programming. And even where it's provided, it limits the ability to use those programs, to go and seek them out for safety. And also, as we think about these combination prevention studies, many of which are being launched now, we have to think about how we're going to address stigma, either as a component of the trial or ultimately how we're going to translate that trial into meaningful programming. We're going to have to think about that transition between efficacy and effectiveness. Also, a large group of people within our Key Populations program, a lot of partners around the world that do this work in extremely difficult contexts, the Center for Public Health and Human Rights where I work, and then a series of others. So thank you very much.
Thanks. Hi there. We're going to shift gears a little bit now, and the rest of the presentations are going to be talking about criminalizing people living with HIV. And first of all, I declare that I have no conflicts. This is who I've done some work for in the past. So what I want to do is I want to basically paint for you where things stand in the criminal law now in Canada, and I've called this presentation not back to the future, but rather fast forward to the past, because I think we're actually at risk of going back to the bad old days, and I think the courts, well, particularly our highest court, has been unfortunately leading us in that direction with a recent decision. So, but let me go back to the past for a moment to get you to where we are now. The first time the Supreme Court actually considered the question of whether people living with HIV might be criminally prosecuted for the question of not disclosing their HIV positive status and potentially some other sexually transmitted infections was in a case that probably many in the room have heard of before, the Courier case in 1998. And the thing to take away from that decision was that there is a legal duty to disclose under the criminal law where there is a significant risk of transmission of HIV. And the fact that the person who has HIV has not disclosed has led to their sexual partner consenting to sex that they would not otherwise have consented to. So basically, the non-disclosure is treated in law as a fraud, and that fraud renders your sexual partner's consent to sex invalid, and therefore your otherwise consensual sexual encounter becomes an assault in law. And in fact, it becomes an aggravated sexual assault, which is a very specific provision in the criminal code, the most serious form of assault in the criminal code that carries a potential penalty of, maximum penalty of life in prison. It also carries a mandatory designation as a sex offender, and that's presumptively for life, but at least for a minimum of 20 years. So just to note, actual transmission of HIV is not required for someone to be convicted on one of these charges. The offense is exposure without disclosure to a significant risk of transmission. So what then is a significant risk? Based on the facts in the case that was before the court, the ruling stands for the proposition that unprotected vaginal sex meets that threshold of posing a significant risk of transmission in the court's view. And therefore, by implication, given what we know about per act risks of transmission, unprotected anal sex also would rise above that threshold. The one small silver lining, or so we thought, as a result of our interventions in the court case before the Supreme Court, was that there was an openness to the possibility that there might be what we might call a condom defense or a safer sex defense to these kinds of charges. A majority of the Supreme Court said that the careful use of condoms might, and I stress the word might, be found to reduce the risk of harm enough that it was no longer significant, at least for the purposes of the criminal law, and therefore there would not be a duty to disclose and therefore no crime. Two of the judges who concurred in the outcome actually went further, including the now Chief Justice, Beverly McLaughlin, and they said very explicitly, only unprotected sex, so sex without a condom, should actually attract criminal prosecution if a person does not disclose. So they were very clear that a condom alone should suffice to relieve the duty to disclose and to protect you basically against prosecution. I note that because the Chief Justice, in fact, has now taken a rather different position in the most recent court decision. But that was what we were able to get in 1998, and in fact, most of the cases that followed in lower courts, that are obviously following this direction from the Supreme Court, as they must in law, actually did begin to accept this condom defense, or exception, if you will. And most of the decisions that came forward, courts actually ruled in one way or another against criminally prosecuting people who had practiced safer sex, even if they had not disclosed. Some of them said that explicitly. Others basically followed the language of the Chief Justice at the time, or the now Chief Justice, in saying that the prosecution has to prove that the sex was unprotected, so that no condom was used, in order to get a conviction. A couple of courts were a little more equivocal about it and said, well, condom use or not is one factor to be considered in assessing the risk, and every case is going to be different. And that's a bit weaselly, but that's what some courts were doing. Overall, however, it seemed that in the law, the position was becoming reasonably well settled, although not 100%, that in fact, condoms would probably suffice and that there would not likely be a conviction in such circumstances if you did not disclose. Well, along came one court that decided to throw a wrench into that emerging picture in the case law. And it was a case called Mabior in Manitoba. And the trial court decided that, in fact, no, a condom alone is not good enough to protect you against prosecution and conviction, nor is an undetectable viral load on its own. In fact, you have to have both. And only if there's a condom used and your viral load is undetectable do you not have a duty to disclose that you have HIV. That issue was appealed and ultimately went up to the Supreme Court of Canada, and so the court revisited it, and I'll explain what happened in a moment. The other issue that emerged since the first time the court looked at this issue in that case, where there was a suggestion that condoms might be enough, was of course the question of viral load, because at the time that first case came before the courts, we didn't really have the same body of science about the impact of treatment and someone's viral load on risk of transmission. But that evidence, in fact, began to come forward, and it ultimately led to the somewhat controversial Swiss statement that some of you may have heard of in 2008, where the Federal Commission on HIV in Switzerland actually came out and said, look, based on the science that we now have, we don't think that someone who has HIV is sexually infectious if they are on effective antiretroviral therapy for at least 6 months and have no other sexually transmitted infection. And they proposed that the risk was infinitesimally small, and they did this in part as a reaction to the rather broad and troubling use of criminal prosecutions in Switzerland. And in fact, this intervention by scientists in Switzerland led the prosecution in one case to appeal a conviction that the prosecution had obtained at a trial court, because the prosecution said, we think there's been an injustice done here. We shouldn't have had a conviction based on what we now know about viral load and the risk of transmission. And so that's rather unprecedented that the prosecution would appeal its own conviction that it had obtained, and indeed an appellate court in Switzerland overturned that. And of course, there's been more science that has come out since, and I've summarized a few key things here, that shows us the dramatic reduction on the risk of transmission that is associated with viral load. In fact, I note here the most recent thing that's been published just recently by Mona Lutfi and colleagues was a systematic review of 6 studies in which they found the rate of transmission was 0 per 100 person years when we're talking about full suppression of viral load. So those issues, condoms and viral load and their legal significance, were the 2 issues that were front and center in front of the Supreme Court in 2 cases. One from Manitoba, the case I've mentioned of Mabior, and one from Quebec. In both cases at the courts of appeal below, where we intervened, we were successful in convincing the courts of appeal that either condom use or an undetectable viral load actually reduces the risk of transmission sufficiently that the criminal law should not apply where people do not disclose that they have HIV. That was encouraging, but then the prosecution took the matter further to the Supreme Court of Canada, and unfortunately, we've now taken a giant step backward, thanks to the Supreme Court. And it's important to stress that because there was much confused reporting on the Supreme Court decision when it came out last October. And the initial framing of this decision was that it was somehow a great victory for HIV activists because the court had allowed for some limits on prosecution. It is true that they did not accept the particularly reprehensible and draconian position that the prosecution was urging before the court, that people with HIV are criminals merely for the act of not disclosing, regardless of whether there was a risk of transmission or not. And that was an incorrect framing because, in fact, as I've explained, courts actually had gone further than that. Courts had actually accepted that either condoms or an undetectable viral load would suffice. Well, the Supreme Court of Canada, led by the now Chief Justice, Beverly McLaughlin, said, no, we're actually going to do a rather significant departure from what she herself had argued and held before. And they purported to say we're going to maintain this significant risk of HIV transmission test, but then basically went on to eviscerate it in the rest of the judgment. And the phrase that you must now remember that is the controlling legal test is there a realistic possibility of HIV transmission? If so, then it's a crime if you don't disclose. So of course, we're back to the same question, slightly differently worded. Well, what is a realistic possibility for purposes of the criminal law? And basically, almost any risk, in the court's view, is considered a realistic possibility of HIV transmission. And I draw that conclusion from the judgment because while the court is at some pains to say, well, we don't want to criminalize very small risks of transmission, they actually go on then to do exactly that. So it's an internally inconsistent judgment, but this is what we're now stuck with. So using a condom is not on its own sufficient. Having a low viral load is not on its own sufficient. Now, I should note here, if there is a silver lining to be had in this judgment, and I'm grasping at straws here, the court actually allowed a somewhat higher threshold than an undetectable viral load. Based on the evidence they had before them, they said, if you had a condom on and you had a low viral load, it doesn't have to be undetectable, it has to be low. And what they said in the judgment was that means below 1,500 copies per milliliter, then and only then will there be no duty to disclose that you have HIV. Now, we can say that with some certainty as it relates to vaginal sex. The court did not address other circumstances. So, regardless of your viral load, if you're going to have unprotected sex, you have to disclose. Regardless of, even if you're using a condom, if you have a viral load that's anything higher than low, you have to disclose. So, as I mentioned, 1,500 copies per milliliter is what the court said in this case was a low viral load. We don't know yet about how the court will deal with a case of non-disclosure in the circumstance of anal sex, and whether condoms and a low viral load will suffice. That remains to be fully tested. One hopes that's where they will draw the line, but we don't know for sure. And the court said nothing about oral sex. So this is a major step backward in my view. It's counter to international recommendations, and it basically fails to take into account the science that has emerged since this issue first came before the court. It leads to a disproportionate and overly broad use of the criminal law, and I think we've already seen from some of the analysis of data that we have, partial though it is, that it has a disproportionate impact on certain communities. I also just want to stress that there is no distinction in the law based on the circumstances of a particular encounter, including the type of relationship. So the way we live our lives might lead some of us to think in some circumstances there really isn't a reasonable expectation of disclosure of such things, and yet that so far is not something that the law has been willing to take account of. So I just want to conclude, I'll leave some resources up here while I say a few things. Post this decision, we need more than ever guidelines for prosecutors to limit the application of what is a very broad scope of the criminal law. At the same time, the job of getting those guidelines in place to limit the application of the criminal law in practice has actually just been made that much harder by this rather unfortunate Supreme Court decision. That then leads me to say, well, so how do we actually get such guidelines in place, and how do we limit in practice the harm that the criminal law can do? And I think there are a few things that need to be kept in mind. First of all, the Public Health Agency of Canada has, so far, been largely missing in action on this issue, an issue that is of great concern to people living with HIV across the country. We hear about it all the time. Frontline service providers hear about it all the time. The Public Health Agency of Canada has had recommendations put to it for years and refuses to touch this issue. I find that unacceptable. It's also, I think, a time for researchers, and I speak to a conference of researchers, to actually step up, for Canada's scientific community to step up. Researchers have a key role to play here. Science, we had hoped, might have actually helped inform the law. It has had limited success so far. However, the voices of scientists have been largely missing from that effort. And so I ask the scientists in the room, please help community get appropriate limits on the criminalization of people living with HIV. And that means at least three things. I think it means taking care with how you release data and how you frame data. The very useful and interesting research that was done for the mail call study, for example, has unfortunately led, just over the last couple of days, to an extraordinarily damaging headline in the Globe and Mail that basically suggests the vast majority of gay men and other MSM in Canada support criminalization of non-disclosure. If you actually look at the data, it doesn't actually quite say that so simplistically, but that is the take-home message people have heard, and that will legitimate people's deep-seated stigmas and prejudices. When we see the injustice, the second thing that scientists can do is actually speak out about it. And the third thing that I ask you to do is refuse to testify for the prosecution in these cases. Refuse to be refuse to be handmaidens to the ongoing stigmatization and persecution of people living with HIV in Canada. If you want to have the trust and the confidence and good working relationships with the communities that you work with and that you study and that you depend on to do your research, then don't help send them to jail. Thank you.
So we're going to see a quick video from Michael Vaughan, who is from the BC Civil Liberties, but couldn't be here tonight, and that will be brief. And then we'll ask Michael Fetter to come up and speak to some of the implications of HIV non-disclosure in British Columbia. And we've been given the room for a little bit more time, so we hope that you'll consider staying for a little bit longer, and we'll take a few questions at the end. So the video will be next.
Go right in.
Okay. So this is Michael Vaughan talking to you from the holodeck, I guess. Sorry that I can't be there personally. Nice to be on the panel virtually, though. I'm going to talk a little bit about specifically the Maybe Your decision and its implications for HIV testing. So the BC Civil Liberties Association recently put out a resource on HIV testing and your rights. And we left some fudging around the issue of what the consequences of the Supreme Court of Canada decision would be because we published before it happened. So Maybe has now come down, and it's very, very clear that the implications for testing are serious. They're serious because there's no doubt that the standards have been raised to the point where there really are hardly any circumstances where you aren't in criminal jeopardy for non-disclosure to a sexual partner. Very, very few circumstances. So this is obviously something that people need to know before they test, not after. Before they test, because there are a series of circumstances in which it would be incredibly difficult, I mean beyond the ordinary difficulty of disclosing to a sexual partner. Those would be circumstances obviously of abusive or violent relationships, and certainly people who are living with active addictions may also have above and beyond the ordinary challenges in terms of disclosure. So from our perspective, for informed consent for testing, what you need is a discussion about what your obligations would be if you did test HIV positive in order to inform whether or not this is a good and safe time for you to test. As we put it, there's more than one kind of risk. And we're encountering two forms of resistance to having that discussion with people who are looking to do an HIV test. One is a very sympathetic form of reluctance, and that is that healthcare providers feel that they are challenged to know the law well enough to give quote-unquote legal advice. Concerned that providers are not able to outline the law in a way that is comprehensive in order for people to understand what their obligations would be. So the answer to that is that this is not legal advice. It's legal information. It can be summarized in one sentence. We need to be able to educate providers to provide at least enough basic information for people to understand that the disclosure obligations are almost uniformly ubiquitous, very few exceptions, so that they would be able to understand that and make their own choices on the basis of that. So that's one kind of challenge. The other kind of challenge is, especially in the context of British Columbia, where we now have a new HIV testing environment that is looking towards routine testing and, to use the language of some of the providers in this sense, a streamlined process of very minimized pre-test discussions. So that's been another form of challenge. Obviously, you need a quite fulsome discussion to talk about the ramifications of testing positive that seem likely to be not occurring in some environments, certainly in the acute care setting environments where we've recently introduced opt-out testing and the like. So those are some of the challenges that we have around what's happening, the ramifications of criminalization of non-disclosure in the HIV testing realm. The other ramifications are, of course, relating to service providers, both healthcare and community-based service providers, in regards to records. Ethical and policy implications of what it means to have people disclose to you that they have not, in fact, told their partners, the kind of counseling that used to be and may still be quite common, where people are looking to their service providers to role play and give them advice and guidance in how to disclose to partners. Now, any recording of those conversations, any records that are kept, are quite risky in the sense that those records could, of course, be subpoenaed by a court as evidence that the person had not disclosed to their partner, and again, contribute to their criminal jeopardy. So ethical and policy considerations about what we tell people about conversations that we are having around disclosure to partners, how those get recorded. These are, again, some of the implications that really need to be seriously thought through for all kinds of service provision. And finally, in regards to HIV testing, the Maybeer decision, I believe, makes it more likely that we're going to see an increased demand for home test kits, and also some demand for the anonymous testing pilot that is in the works right now. How people are going to regard the kinds of testing options that we have currently in light of the jeopardy that has been introduced by the new standards in Maybeer can only suggest that those kinds of testing options are going to see increased demand. I suspect my 6 minutes are up, and I wish I was there to take questions, but I'm pretty sure Richard or Michael will be able to handle any questions that come out of the prepared comments that I've been able to make for you. Okay, thanks lots. Bye.
Good evening. I want to make sure that there's a chance for questions, so I'm going to be very brief. I do want to touch on three things. The first is the situation in BC as regards prosecutions for non-disclosure of one's HIV status. The second thing is prosecutorial guidelines in BC. And the third thing is I want to pick up on the discussion about Maybeer and offer some criticisms from a lawyer's perspective, specifically a lawyer who was involved in the case and whose arguments lost. But I think my criticisms are nonetheless valid. I have looked, and I can say that since Maybeer in DC, there are no reported cases of HIV non-disclosure prosecutions in BC. Those cases were only decided in October, so it is possible that there are prosecutions working their way through the system of which I'm unaware, but so far so good. And even before Maybeer in DC, there had only been a handful of prosecutions. I found 5 reported judgments in the preceding 5 years. One of them was a quite serious case involving actual transmission. Another involved no transmission, but willful attempts to transmit, and the other 3 did not involve any transmission at all, and probably, in my view, ought not to be criminalized. But post Maybeer in DC, we've seen nothing new. In terms of prosecutorial guidelines, BC is unique in that we're one of only 2 provinces in Canada where prosecutors, as opposed to the police, lay charges. And charge approval is subject to a 2-part test. There needs to be not only a substantial likelihood of conviction, and what Richard has described about Maybeer will spell out whether that part of the test can be satisfied, but in addition, even where there is a substantial likelihood of conviction, a prosecution must be required in the public interest. And the Crown Counsel Policy Manual spells out a number of factors that relate to the public interest requirement, including the length and expense of a prosecution when considered in relation to the social benefit to be gained by it, and the extent of the harm caused by the crime. And I say that given those 2 factors, there is lots of scope to argue that no prosecution under Maybeer is justified in the public interest, or at least in the vast majority of cases it would be unjustified. In addition, in BC, there is a specific policy pertaining to sexually transmitted infections. That is a specific Crown Counsel policy. And the policy hasn't been updated since Maybeer and DC were decided. It dates to 2007, and I say that's very good news because it describes unprotected sex as a requirement for a prosecution. And based on Maybeer and DC, actually that's no longer a requirement. In theory, you could prosecute based on use of a condom, but a non-low viral load. The policy is also interesting in a few different aspects. First, it requires any prosecution for HIV non-disclosure to be reported to a medical health officer. Second, it requires the decision whether to prosecute to take into account conditions with which the medical health officer has the power to impose. And third, it requires a high-level review of any charge by regional Crown Counsel or his or her deputy. And it seems to me that that sets a very high barrier to any prosecution. There's a lot of hoops to be jumped through, and I think it's intended to signal that this is first and foremost a public health issue. The good news I take from all of that is that the number of prosecutions I would expect to see in BC post-Maybe or in DC is low, and I think there's lots of scope, as I said, to argue that there should be very few. The bad news is that for healthcare providers and for people living with HIV who need clarity about disclosure obligations, the fact that there exists this discretion and this policy doesn't change what the Supreme Court of Canada has said about the law. I just want to finish by offering one lawyer's perspective on what is so wrong about what the Supreme Court of Canada has done, and I agree with everything Richard has said about it being sort of a trip backwards. But I see 5 things that are wrong, and 3 of them relate to the way in which the criminal justice system is supposed to function, and 2 of them relate to public health concerns. My first criticism is that Maybe or in DC turned the creation of a statistically insignificant risk of transmission into a very, very serious crime punishable by life in prison. That's inconsistent with the fact that sexually transmitted infections are first and foremost a matter of public health, and it's inconsistent with the idea that our criminal law is supposed to be reserved for only the most blameworthy cases. My second criticism is that it is totally inconsistent with the way in which Canadian law otherwise treats consent to sex. And I say that that inconsistency is driven by stigma and prejudice about HIV. And I'm not going to give you a lecture on the law, but I will simply say that Canadian courts don't care, generally speaking, about people deceiving their partners in order to induce consent to sex. A person can go and say, I'm unmarried, I'll marry you if you have sex with me. I'm a Muslim. You can say whatever you like, practically speaking, and it doesn't matter. The consent is good and the court does not care. However, if in the absence of a question you neglect to disclose that you have HIV, and there's a 1 in 10,000 or less chance of it being transmitted, that is sufficient to turn your otherwise consensual sex into an aggravated sexual assault. My third criticism is that it doesn't differentiate based on the resulting harm. There's no differentiation between transmission and non-transmission, and I say that's simply absurd. The vast majority of prosecutions don't involve any transmission, yet they're treated the same way as those that do. My last 2 criticisms are the public health ones. I say that it creates a false sense of security and discourages personal responsibility for sexual health, and that criticism arises, of course, because, as Richard has said, the duty to disclose arises in every context, no matter the nature of your relationship. In theory, one needn't ask any questions or worry about anything. You just need to wait around and have your partner tell you. And my second of my 2 public health criticisms relates to Michael's remark about testing. I think it inhibits testing for the very reason she's given, which is that informed consent to testing requires disclosure of what your disclosure obligations are going to be if it turns out that you're living with HIV. And obviously, something that inhibits testing, inhibits treatment, and that is most undesirable. Thank you very much.
Thank you so much. I want to thank all of our panelists. And I also just want to note that this is a session that carried over from a session that we had on Thursday around stigma and HIV. And at that session, we did talk about criminalization of drug use, but we couldn't cover that in this session. So it was something we spoke about before. So I just want to open up the floor and see if there's any questions. I think we can take a few minutes for questions if there are any. So yes, no, there's a microphone there.
Hi, thanks to all the great panelists. I think I know everything about this topic, and then I come to the session and I learned something else. Over the last few days, I have attended a lot of different sessions, but I remember hearing some research that continues to suggest that, in point of fact, the criminalization issue is not having a dampening effect on testing. Am I making that up, or am I continuing to hear that that is the case? I, just heard the last speaker, mention from a public health point of view that it will drive the epidemic underground, and we've wanted to believe that for a very long time and use it in our arguments. And I know we're going home to do some work, the working group on criminalization, and I think we're really going to have to wrestle with this issue of how we create arguments and deal with the data that we are getting thus far in terms of whether or not failure to disclose, the disclosure issue is really having a dampening effect on testing. So I'll ask panelists for any comments on that, how we should continue to wrestle with the issue. Do we have sufficient data? Do we not?
Sure, I'll tackle that. I think it's fair to say that from the beginning, advocates who have been raising concerns about criminalization have advanced a number of concerns. The concern about the impact, the negative potential impact it has on willingness to test has been one of those concerns, but it's by no means been the only one. But I think, and for the longest time, there has been a real dearth of data on that question, and that's rather unfortunate. In fact, the dearth of data on that point was commented upon very specifically by the Supreme Court back in 1998 when the issue first came before them, and they basically just dismissed the concern out of hand. Now, I will say, because they said there's no evidence in support of the concern that interveners are raising, they were willing to accept with an equal lack of evidence that the criminal law would in fact have a deterrent impact on people practicing risky behavior, and it would encourage people to disclose. There was absolutely no evidence before them for that proposition either, but they were willing to accept that one. So I think there was an inconsistency in the approach. But now we do have a little bit more data coming out. There was a study published the year before, last year actually, from Ottawa amongst gay men, finding that a minority, but a not insignificant minority of men, and in particular men who are engaging in high-risk sexual practices, in fact, were concerned about seeking testing because of the risk of prosecution. The mail call data that was just released, 47.5% of the men who have sex with men in that study agreed that it deters testing. 17.7% of them agreed that it's better not to know your HIV status in the current legal context. There was a study, I gather, presented yesterday, the headline message of which was suggesting that no, it's not really a big deal. Only 7% said it was of concern. But not having yet looked at the study carefully, I understand it's a study done amongst men who are already at an STI testing clinic. So you've already got a built-in bias. People who have already decided to actually seek out testing, you're probably not going to get a significant percentage of them saying a concern about possible prosecution is a deterrent to testing. So I'm not sure that that figure is really all that useful. So I think we need more data on this point, but I think we also have to be prepared to accept that the data may well be equivocal. And I think, as is the case with most of the criminal law, it's easy to make overstated claims about its impact one way or the other. And I think the reality is the criminal law has a deterrent effect for some people some of the time in some circumstances. And I think you will see that here, whether we're talking about deterring testing, deterring disclosure, deterring unsafe sex, you're going to see a mixed result. However, to the extent that you are deterring people from seeking testing, and particularly if you're deterring people who may be at higher risk, then there's a potential public health impact that flows from it. And I think that ought to be of concern to us amongst all the other concerns that criminalization raises about cases of personal injustice, for example, against people living with HIV.
Just to speak to that last point that Ron brought up, I do agree that that we don't have the final word on the impact of testing or the impact of prosecution on testing rates. And I, for one, was very concerned that this might be an issue, that it might drive people underground. And I guess we don't really know definitively. However, data that I think is important to point out is in a subsequent study from Ottawa, published about 2 months ago, we found there was no decrease in testing among MSM in Ottawa following the very public case that was widely publicized in the media in May 2010. No decrease in testing in the 4 months subsequent to compared to the 4 months before. And in fact, there may have even been some increase in the positive tests among MSM, although that was not significant. Our study that Richard referred to, which we presented yesterday, which Maya Kessler presented, was in a group, not in an STI clinic, but albeit a not necessarily representative sample. It was a group of people in care at the Maple Leaf Clinic in Toronto. And we specifically asked people who are already HIV negative who might consider having a subsequent test. And only 7% said that they were less likely or much less likely to get tested because of a fear of prosecution. The other point I might want to make is that, testing doesn't make people positive. Testing allows people to know whether they're positive or not. And not getting tested, although I still agree that there's a residual concern, although less now with some of the data coming in, is that people will eventually be diagnosed when they become very ill, or because one of their partners who they may have infected come to light, or because their baby, for example, develops AIDS in the early years following mother-to-infant transmission. So testing does not cause infection. Testing just allows people to know about a situation which is already there, and testing will obviously benefit them, will benefit their sexual partners, will benefit their newborn children. So I think that we do need more research. These couple of instances are, I think, encouraging, but not, I agree, definitive.
Just a second. Yeah, so we'll just take one more and then we'll wrap it up.
I was just wondering around the statute of limitations around this. I mean, in regards to the disclosure of...
There is none.
Great. So I think we will wrap it up because we've gone quite a bit over, but please join me in thanking our panelists for great talks. Thank you.